Let's continue with our lectures on the aorta. So we're going to talk about aortic dissection now. We just talked about aortic aneurysms in our previous lecture. Now we're going to talk about, again, aortic dissection. And there is a distinction between the two. Again, in the aortic aneurysm, you have a weakening of the inside of the artery, or the aorta. In this case, we have a false lumen between the layers. If you remember, your artery is composed of three different layers: your tunica intima, tunica media, and the outermost layer, the adventitia. Okay, so let's not get caught up in all those names. Just remember that the insidemost layer, and here I have a, let's say that this is an artery, and again, if we were to, this is if it is heading in this direction. If I were to turn it around and having look straight at you, this is what that drawing, this drawing here is supposed to mean. So the innermost layer again is the intima. Now the layer right above that is the tunica media. Now again, in the aortic dissection we have a false lumen. So same thing, typically most caused by high blood pressure. So what will occur is there will be a tear in the intimal layer, the innermost layer. Along with that blood pressure, it's going to cause blood to become accumulating in this space. And so again, this is what causes that false lumen. Now this is different than in an aneurysm, because in an aneurysm you would have the entire vessel coming up. Okay, so that's the difference. Here again, you have a separation between the layers. So if you forget that black area there, again we have a separation between the vessels. You can almost end up with the same result. Again, we're talking about the aortic dissection, so it'll depend on where this dissection is occurring. Here I have the heart. Remember, the heart is going to ascend, so this could be known as the ascending aorta. It's going to branch off into a couple of different subclavian arteries, carotid artery. So this would be the right side of the patient. This would be the left side of the patient. This will all come into play here later on when we talk about our interventions and clinical manifestations. So this is right side, left side. So again, blood is going to come up. It's going to go into the carotids, feeding the brain. It's going to come into the arms, feeding your upper extremities. The aorta will come down, feed your gut, your small, large bowel, feed your kidneys, come down to your femorals, feed your lower extremities. If, however, we have, for example, a dissection occurring, for example, here I just drew the same aorta. Again, we have here the intimal layer. If we have a dissection or a false lumen creation, for example, in the ascending portion, like here, we are going to have blood trapped in this area. Okay? So if we have blood accumulation here, that is going to make it less likely for blood to continue here. So again, less blood is going to go to the carotids, less blood is going to go into the arms, and less blood is going to come further down into your bowel, kidneys. If, however, for example, let's say that there is no dissection there, this is perfectly fine. We go a little bit further down. Now this is descending, it's going down, so this is typically known as the descending aorta. So for example, if we have a dissection here, let's go here. If we have a dissection in this area, well, now the kidneys have the potential to not receive the blood supply that it needs, because again, blood is leaking out of the aorta and coming into that dissection. So staying stuck there. Now again, if blood ever sits in one spot, it has the potential to coagulate. Okay. In any case, blood is being diverted from the vital organs, in this case the kidneys. So let's take a step back. Let's focus on some causes. Number one, hypertension. Hypertension again is going to cause increased pressure, in this case in the aorta. This can lead to a intimal tear. Okay, so again, we talked about high blood pressure causing many different pathologies on our lecture on hypertension and on atherosclerosis. So again, this increase in high blood pressure can lead to an intimal tear, the innermost portion of the artery or the aorta. Now again, this tear will most likely increase during heart contraction or systole. Now again, depending on the size and the location of the dissection, this will decrease the amount of blood supply to that area. Again, we talked about here, if it is in the ascending portion, typically the carotid arteries, again the arteries that take blood to the brain, will be affected. Here we have the right subclavian. This is going to go into the arms. Okay, this would be the right arm, this would be the left arm. And off the subclavian you also have the other carotid artery. So again, if this portion is affected, if we have a dissection occurring in this area, we have blood pooling here. Again, blood cannot come up into the carotid arteries. Blood cannot go to the brain. The patient will have different complications. So again, let's focus on the causes. Number one, hypertension. Number two, trauma. Marfan syndrome, cocaine use, pregnancy. So trauma can cause a weakening to the aorta. Cocaine and pregnancy, one of the problems that we worry about later on when we get into maternal-child pregnancy, something like eclampsia, preeclampsia. Again, these are going to increase blood pressure. Again, if we have severely high blood pressure, then we always worry about causing a tear to the arteries, in this case the aorta. Okay, so we always want to control blood pressure. Blood pressure being high can cause a lot of problems. So let's move on to our clinical manifestations. Number one, chest pain. Now this chest pain will be sharp, and it will also radiate to the back, to the shoulders, to the neck. Patients often again complain of it being a sharp pain or maybe a tearing or a ripping pain. So always ask the quality of the pain. Ask them to describe the pain. Again, a lot of patients say it feels like a tearing or a ripping pain, a very, very sharp pain. Number two, on our clinical manifestations, signs and symptoms, altered mental status. Again, if it is in the ascending portion, we just talked about how the blood supply to the carotid arteries. Again, this is going to turn into it's going to lead into your brain. So if this blood supply is decreased, the patient will most likely complain of altered mental status, or you will notice some altered mental status, changes in their level of consciousness. That decreased blood supply to the brain may result in syncope or the patient fainting, dizziness. If you were to take their carotid pulses, you'd find that the carotid pulses may be decreased. There may be some changes in the carotid pulses. So again, you want to assess your patient very, very carefully. Angina or angina, depending on your pronunciation. This will result, this results because of decreased blood flow to the coronary arteries. Remember again that when the heart contracts, yes, it's going to push blood throughout the body, but it is also going to push blood to itself by way of the coronary arteries. So if the blood supply is again decreased, you always run the potential of that blood supply being decreased to the coronary arteries. If that occurs, patients won't complain of that chest pain, that angina. Again, this has to do to that decreased blood flow to the coronary arteries. Number 4, if it is chronic, patient may suffer from left ventricular failure. Remember, the blood supply must be maintained, so the left ventricle will begin to pump harder. Again, it is a muscle, so it will increase in size. It will hypertrophy. Again, increase in muscle size. Now, over time, the effectiveness of the heart's pumping ability will decrease. Again, that will result in left ventricular failure. Along with that, you will have decreased cardiac output, so you may have some pulmonary edema. So you always want to auscultate your lung sounds. Patients will most likely, if they are having pulmonary edema, they may also have some dyspnea. You may notice some jugular vein distension, some edema or peripheral edema in the lower extremities. Now, number 5, changes in radial and ulnar pulse, changes in blood pressure. Why? Well, earlier I talked about how, again, let's say that this is perfectly normal. There is no dissection there. But let's say that the dissection is occurring maybe here and here. Okay, there's a huge dissection here. Now remember that the subclavian artery here is going to go down to your arm. So when you palpate for a radial pulse, again, every time the heart pumps, boom, you're going to feel that pulse here. Because again, this blood is being pumped to the right side of your arm. If, however, there is a dissection here, well, the amount of blood supply coming to your left side of the arm is now being affected, because blood is now pulling up here in the dissection, which affects the amount of blood supply to your left arm. So you may have a different pulse in your left arm than you will in your right arm. So again, you'll always want to assess for changes in the radial pulse, changes in blood pressure. Is there a different blood pressure reading on your right arm versus your left? If so, again, that may be indicative of some type of dissection, aneurysm, or in this case, we are talking about aortic dissection. Okay? So that is why you would get this difference in pulses and in blood pressures. Number 6, decreased tissue perfusion. Okay? We talked about if it occurs, for example, down here, if it is a descending aortic dissection, if, for example, maybe your kidneys are not getting the blood supply that it needs, well, then it will result in decreased tissue perfusion or decreased blood supply to the organs, in this case the kidneys, and we'll talk about that here a little bit later. Let's focus on some complications. Number 1, cardiac tamponade. We talked about this in our lecture with acute pericarditis. So if you haven't seen that, go back and check it out. So again, complications. Number 1, cardiac tamponade. Now this will result from blood from the aortic dissection leaking into the pericardial sac. Remember that cardiac tamponade is just fluid in the pericardial sac. So if you have increased fluid in this pericardial sac, that increase in fluid is going to have an effect on the pumping ability of the heart. The heart will not be able to pump effectively. It will not be able to pump like it should. Therefore, cardiac output will be affected. Again, this is due to increased heart pressure. Again, the fluid is accumulating around the heart, causing more pressure on it. That pressure is going to result in decreased cardiac output. Also, the heart can't pump like it should. So if you were to get an ECG, you would see some dysrhythmias occurring. Okay, now again, if you have a decreased cardiac output, the patient may suffer from some hypotension, jugular vein distension, Muffled heart sounds. Again, you'll have the muffled heart sounds due to that fluid accumulation in the pericardial sac. You'll have something known as pulsus paradoxus. So again, check out the lecture on acute pericarditis so that you can remember cardiac tamponade. Number 2 on our complications, rupture. Now again, the aorta is the major transporter of blood from the heart to the rest of the body. So if this were to rupture, all of this blood is going to leak out. You will have no blood supply to the brain, no blood supply to the arms, no blood supply to your abdomen, kidneys, to anything. So patients, if there is a rupture, will suffer from hypovolemic shock. If this patient does not receive medical treatment immediately, death will occur due to hypovolemic shock. So we always want to prevent rupture. Number 3, this goes off of our one of our clinical manifestations that I previously mentioned, decreased tissue perfusion. Again, if for example, kidneys do not get the blood supply that it needs, renal ischemia will occur. This simply means decreased blood supply to the kidneys. This may result in renal failure. So again, we're always worried about all organs of the body receiving the blood supply that it needs. Again, if the kidneys do not receive the blood supply that it requires, renal failure may occur. So again, here, you always want to look at your urine output. And so within normal limits, check out your BUN and creatinine. Is there any elevations in these? Again, these would indicate good or bad renal function. Number 4, abdominal pain. Again, if the blood supply to the large bowel, small bowel is affected, you'll have decreased bowel sounds or hypoactive bowel sounds. There will be changes in their bowel patterns, their bowel function. Again, this is due to that decreased tissue perfusion, decreased blood supply in this case to the large and small bowel. Diagnostic studies. You can do a couple, but really gold standard is CT. You can do a chest x-ray. If you do chest x-ray, you maybe see some pulmonary edema, some heart enlargement. You may even see a large aorta, a dissection. But the gold standard, as always, is CT, or something known as TEE, transesophageal echocardiography. Okay. Again, if you see this on the Nclex exam, if you're going to have a CT study done, make sure that they're prepared for the CT exam. If they're going to receive iodine, is BUN and creatinine within normal limits, so on and so forth. Okay, do they have any allergies to shellfish? Any allergies to iodine? Now, something else could be done, for example, an MRI. I don't really list it on here because, again, if, for example, your patient has a pacemaker, they may not be able to have an MRI done. Okay. Treatment and interventions. Number 1, you want to control blood pressure. Again, any increase in blood pressure will make it more likely for that dissection to rupture. So again, you want to have a good control on blood pressure. You want to maintain blood pressure at a low level. So patients may receive something like esmolol, calcium channel blockers, the ACE inhibitors, propranolol. Number 2, you want to control pain. You want to decrease pain because, again, if the patient is complaining of severe pain, blood pressure most likely will also increase. So again, you want to control pain. Now, along with pain control, you also want to monitor their level of consciousness. Monitor for any altered mental status. Because, again, depending on where the dissection occurs, if, for example, carotid is not receiving the blood supply that it needs, well, that may change, that may cause some mental changes. You give that patient morphine, Dilaudid, that may also decrease their level of consciousness. So again, always pay close attention to their level of consciousness. Patient may get something like an endovascular dissection repair. Or number 4, surgical repair. Now the exact procedures, the steps for all these is beyond our lecture here. So let's focus on the pre-op things that you need to know and the post-op things that you need to know for the Nclex exam. Number 1, pre-op, you want to maintain your patient on bed rest. You want to maintain a semi-upright or semi-Fowler's position. Again, this is in hopes of maintaining a low systolic blood pressure. Again, you do not want this patient moving around, doing or lifting anything heavy, because again, that's going to increase blood pressure. As like I mentioned before, we want to maintain or we want to control blood pressure, keep systolic blood pressure down. You want to place the patient on telemetry or continuous ECG monitoring. Again, we always want to monitor for any changes that may be indicative of some pathology worsening. Arterial blood pressure monitoring. Number 4, you want to monitor their vital signs frequently. You want to monitor any changes in pulses. Again, is it changing drastically in the right arm or the left arm? If it is a descending aortic dissection, you also want to assess femoral pulses. Are there any changes there? Number 5, you always again want to assess the level of consciousness. That is pre-op. Now, post-op, please review the lecture on aortic aneurysms, because the post-op care is essentially the same. Okay, now for patients that have a aortic dissection, you must inform them, you must educate your patient that long-term blood pressure control is required. So a patient may be given something like metoprolol. If they are going to receive metoprolol, educate your patient on some of the side effects: dizziness, depression, fatigue. Now you will educate your patient to never discontinue these medications abruptly. We talk about the causes of a hypertensive crisis, one of them being discontinuing or abruptly stopping intake of blood pressure medications. So for these patients, if they were to abruptly stop taking their medication, their blood pressure would come up severely. Now, if they just had surgery to repair a dissection and their blood pressure continues to rise and rise and rise, there could be severe complications. So again, you must make sure that your patient understands to not discontinue these medications abruptly. If they do not like the side effects, you need to inform them to contact their physician. Maybe a different medication can be prescribed. Number 2, you will educate your patient to report any pain, to report any changes in pulse. Again, we talked about how depending on where the dissection is, there may be a difference in your pulse in the left arm versus the right. There may be some changes in blood pressure. So if the patient is complaining of pain, increased pain, along with changes in pulses and changes in blood pressure, this could be a medical emergency. So again, you must inform your patient to report any of these signs and symptoms to the physician immediately.